The optimal patient for sorafenib would be somebody who I don't feel is in danger of progressing rapidly, because sorafenib causes some shrinkage. It may not cause a lot of shrinkage. So I'd like it to be somebody who is maybe not rapidly progressing, but is definitely progressing and is at risk now of developing symptoms from their disease. I also like it to be somebody, I'll prefer sorafenib in a patient who I'm not wanting a too rapid response. There sometimes are areas that are critical that if they respond too fast, they could cause problems. And an example of this is somebody who has possible tracheal invasion or esophageal invasion, very invasive disease in the neck, where I'm afraid that if I actually shrink it too quickly, I can cause fistulas and other really catastrophic complications. So somebody who I want to get some response and slow and steady is a good one. Occasionally there are also patients who, for various reasons, I don't think are as good candidates for the other kinase inhibitors, mostly lenvatinib, which is the other one that's out there. If there are comorbidities that I think they're particularly at risk for, they might be put on sorafenib first, because then they may manage it a little bit better. So the side effect profiles of the different drugs are different. And for that reason, I will often pick somebody with sorafenib first who I'm worried about the comorbidities being treated with the other drug as well. So because of side effects, because of invasive disease, and somebody who is progressing sort of on a more even-keeled or more slower pace, those are people that would probably be ideal for getting treated with sorafenib.
So to me, for patients with sorafenib, it's patients that need to start systemic therapy, that are having a doubling time of their tumor within 6 months, or starting to become symptomatic, or having disease grow in an area that's going to cause really severe symptoms in the near future. These are the patients that you often want to put on sorafenib. The thing you always have to consider is, are you going to choose sorafenib or another drug? Sorafenib has shown to be effective from the decision study in the first-line setting, but it's hard to really say that sorafenib works that well in a second or third-line setting. Other drugs, lenvatinib, cabozantinib, have shown to work very well in the second-line setting. So for that reason alone, sometimes sorafenib in the first-line setting makes a lot of sense. The trade-off is that the response rate and the progression-free survival that we see with sorafenib is actually much less than you see with lenvatinib and cabozantinib and pazopanib. And they have not been compared to head-to-head, so we are looking at individual different studies. It's not the right way of doing things, but it seems to be a big enough difference that most people seem to agree that that response rate and that progression-free survival from sorafenib is shorter. So if you have a person with more aggressive disease, someone you really need a high chance of getting a response, then using one of these other drugs might be the better option. However, for a lot of patients, if you are starting them on treatment with enough time, then starting them on sorafenib can really work, because you can still go to these other drugs. The other drugs can be almost just as effective in the second-line setting, and you really can give the patient a nice extra benefit in treatment, because you can go from one drug to another. The way I sort of always put it to patients is that for most of my patients with thyroid cancer, I feel like this is running a marathon, not running a sprint. If you have to run a sprint, then you get to your best drug and you use that right away. But if you're running a marathon, you're going to be going from one drug to another to another. You don't need to use the best drug. You need to figure out what is going to be the best sequence of drugs that's going to give you the longest period of time of keeping the disease under control.
My personal experience with sorafenib is that we treat many patients with sorafenib in our team. It's a drug that really can make a difference in patients with progression of thyroid cancer who are resistant to radioactive-iodine. It could give tumor regression in quite a number of patients and also resolve symptoms. On the other hand, we know that with those drugs we cannot cure patients, so in the end many patients will have progression, and management of side effects is a very important issue. The treatment and management of side effects should also be done in a setting where there is much experience in managing side effects. In that setting, side effects can be prevented, at least hand and foot syndrome, or they can be managed in such a fashion that quality of life of patients can be preserved as much as possible. So the experience with Sorafenib in our team is extensive, and we really are convinced that our setting is necessary to have optimal treatment for our patients.